That's the way we wrote it. I hope I'm correct. And so she's going to do a nice presentation for us today on bone fragility and Duchenne.
Great. Good morning. Yes, I am a pediatric endocrinologist, and I came back here from Canada in 1985, so it's actually even a little bit longer. And I've been working in the bone area. There aren't very many of us pediatric boneheads, we call ourselves. But I got really interested in this about 22 years ago. And within my bone interest, Duchenne's particularly does keep me awake at night and contributes to my gray hair. So I want to talk to you quickly, actually not so quickly because I know what it's like to translate. I want to talk about why bone health matters, what are the threats, how do we evaluate, and what are the possible management strategies. So it's really important to understand how bones develop in everybody. So your bone strength or your bone bank really does get built early. And so even though I'm a pediatric endocrinologist, I care about osteoporosis for life. And if you're going to build a good bank, you need to work right up through the mid-20s. So this is the concept that basically you have this peak. Where's the pointer? Which is the pointer? Right above the arrows, okay. So you gain bone mass, bone strength, bone size up until your mid-20s, and males get more than females primarily because their bones are bigger. And the concern I have is that for young people who, for whatever reason, go into their adult years with lower bone mass, bone strength, they are at increased risk throughout the rest of their life because as you get older, there are inevitable losses. So if you have a lower deposit in your bone bank and you start withdrawing, you're going to get in trouble sooner. And I do know that in pediatrics that there are children who obviously get in trouble with fragility fractures even as children. So it's important that we are moving away from the idea that there's just this bone density issue. It's really the size and the shape of bone that makes it vulnerable or resistant to fracture. And this has real importance when we think about Duchenne's. So if you took everybody in this room, your risk of fracture, 60 to 80% of it is determined by heredity. And so if your mother had a hip fracture when she was 70, or grandpa had a hip fracture at the same age, you have a higher risk than somebody whose older parents never had a fracture. Well, we don't get to choose the parents that we got genes from, so I always focus on the modifiable variables, and these are the ones. So body mass matters. We used to just think skinny people were more at risk for bone problems, but we have now determined that obese children as well have a higher risk of bone problems. So that's an important variable. Getting enough calcium and vitamin D to give the building block to bone is important. Physical activity is really important because bones only get as strong as they're asked to be, and that is loading the bone, making the bone work against gravity. And then there are important hormones. The most important ones in a good way are growth hormone and your hormones of puberty, your testosterone and your estrogen. In a negative way, we heard about this, high-dose steroids have a negative impact. So the problem with Duchenne's is what I call, unfortunately, a perfect storm. There can be inadequate gains going up the hill and actually increased losses. So the threats, number one threat from my perspective is immobilization. And this has to do with the fact that bones have these little mechanosensors in them. And if there's no stimulation that the bone needs to get used, it doesn't ever form. And these are pictures from children with cerebral palsy. But the theory is the same, that basically if you don't get your bone's working, you have a narrower bone. It's skinnier. It's like a thin straw instead of a fat tube. They're narrower. They have this thinner cortex. No actual difference in bone density itself, but it's the size and the shape of the bone that's an issue. And that's really hard to fix. But the inflammation is also really important, and we've already heard a lot about that. But it does, the inflammation, you make these chemicals, these cytokines that actually cause increased bone loss. And steroids are really necessary, but they definitely have side effects. And I fortunately don't have to go through this much because they've just been outlined. So the benefits are clear, but from a negative standpoint, they do cause bone loss and they do impair bone formation. And they clearly increase the risk of especially vertebral fractures, not so much the leg fractures. But remember that the inflammation and the immobility do the same thing. So even if you never took a prednisone or a deflazacort, you are at risk because of the inflammation and the immobilization for all these bone problems. So those are three biggies in terms of threats, but other ones include delayed puberty, which we know is a common thing in Duchenne's, because then you have low sex steroids and they're good for bone. Vitamin D deficiency can occur because kids aren't out in the sun, or they may not be paying attention to how much vitamin D they get. And the obesity is also a threat. So how common are fractures? This I'm going to go through in terms of age groups. So across the top, age 5, age 10, and age 18. And I'm also going to break it down by where the fractures occur. At any site, there's a 16% chance of getting a fracture at any site. At age 5, it goes up to 37%, and well over half of people will have a fracture at any site by age 18. The spine fractures really don't occur till you're a bit older, because they do seem to occur or begin to occur when you start the deflazacort or the prednisone, and you aren't doing that until you're at least 5 or 6. Fractures we know take a toll. They cause pain, they cause loss of ambulation, and in the spine, I worry a lot about them because they cause pain, but even if they are painless, and many of them are, they can cause a collapse of those building blocks in the spine. Then you have less space in your chest for lung capacity. So how do I approach a patient who has Duchenne's in terms of evaluating their risks for bone problems? First of all, really going through a history of the diet, what extent they're able to do any physical activity, what their dose of steroids are, and what their fracture history is. And then I look at their growth, their puberty, do the embarrassing exam, look at their spine, and look at motor function. And then there are standard blood tests that are done. And I've been so grateful to Dr. Day and his colleagues who have been willing to let me come speak to them and talk about trying to get these screening labs done in the Duchenne's clinic on an annual basis. What about doing a bone density test? I get a lot of people asking me about this. We used to do a lot of these bone density tests. They're called DEXA. And they used to be, in the Duchenne guidelines, recommended to be done annually once you start on steroids. It's a safe, precise procedure. You don't even have to take off your clothes. There's no radiation risk. And we have good normal data. But we're kind of moving away from this bone density business, more towards focusing on fractures. DEXA is not a perfect test of bone strength, because you have to correct for some variables. There really is no set point. You say, oh, that number tells you you're going to have a fracture. And the worst part, or the greatest limitation, is you can have a fracture if you're on steroids, even though your bone density is theoretically in the normal range, because the quality of the bone goes down before the quantity of the bone goes down. So we're moving towards a greater focus on fractures. Now, if you fracture your femur or your tibia, and your child does, you know it, right? You know it. They have pain. They may have, some bone sticking up somewhere. So you know about that, but the spine fractures can be asymptomatic, and they often are. About half of them, you don't feel the pain. And they can occur, again, when the bone density is theoretically in the normal range. Once you've had one fracture, your risk of another fracture in the spine goes up a lot. So these fractures are very concerning, and I don't know how well this projects. But basically, instead of looking like a cube or a block, this one's kind of caved in, okay? Now, this one is clearly caved in. And what happens is your spine length gets shorter, and you may bend forward. And these are not good for your breathing. So, Leanne Ward, who I think is the guru of bone in Duchenne's, has rewritten the guidelines and really suggests that we should be doing more evaluations looking for these spine x-rays. And they certainly should be done when any time a child has back pain. But somewhere up to 56% of patients won't have any pain or any symptoms. Certainly do it if there's low bone density. But maybe, and this is what she's suggesting every year, as soon as you start steroids, get a baseline and then once a year do a lateral spine. We only need to look at the things from the side. Doing a DEXA or not, I don't want to spend time doing that. I'm moving away from the DEXA because it doesn't change what I do, and I don't like to order a single test unless it's going to take me in one direction or another. In terms of management, we have to address all the weak spots, every leg of the stool. We have to address every risk factor. We can't just say, oh, let's give some calcium and vitamin D, that'll fix it. No, we have to look at everything. So optimizing calcium intake, calcium is what we call a threshold nutrient. So you want to get to this magic point between the ages of 9 and 18, total amount of intake, 1,300 milligrams a day. Getting more beyond that does not necessarily benefit you in any way and does increase the risk you might have a kidney stone. The vitamin D is really important because whether or not you can absorb that calcium is depending on enough vitamin D. And the goal is to get to a level of somewhere between 20 and 30 in the blood. In order to do that, you want to get in about at least 1,000 units and certainly safely 2,000 units a day of vitamin D. Fortunately, unlike calcium, it's very hard to get toxic or get too much vitamin D. So you can easily go 2,000 units of vitamin D to help with your bones. What about optimal loading? And this actually applies to everybody, including astronauts. There was an article in the paper talking about an astronaut. Every month they're in space, when they're in weightlessness, they lose 1% of their bone. So this is an important concept that for somebody who's moderately active, in order to change their bone strength, they actually have to do something more vigorous, some high impact loading, some jumping. But if you can get somebody from being completely sedentary, completely immobile, to at least standing, you help to reduce the bone loss. So the prescription, ideally for activity, is to try to avoid, as much as possible, complete immobilization. Now, I recognize that when you do physical therapy, you do run the risk of fracture. Unfortunately, this idea that you could stand on a vibrating plate like the motel bed that gives you a massage, these data really are unproven. There are some small pilot studies, but your physical therapy is so important. And even if you don't feel like, wow, I'm not doing so much, but you're spending some time in a stander or working with a walker, that is going to be so much more helpful than just sitting in the chair. And I know it's hard work. Testosterone therapy comes up in my business if a boy is not in puberty by 14, that's the definition of delayed puberty, and giving testosterone is really another potential benefit for bone. And it can be given as a shot or once a month, or if people don't like that, there's a gel you can put on a daily basis. Finally, there are some drugs. These are drugs that we use in old people for osteoporosis, and we reserve them for when these general measures have been tried and failed. We wish we had what we call an anabolic agent, and that's a drug you give that actually builds up the bone. But for complicated reasons I will not go through here, we cannot use these in children. They can be used in adults. So if you have an adult with Duchenne, you could go there in terms of discussing it. So we're stuck with what we call anticatabolic drugs, and these are ones that reduce the amount of bone loss. So you slow down the bone loss. You're not building up the bone, but you're preventing or reducing the bone loss. And there's a lot of controversies amongst the people like myself who are boneheads about the best drug and what the dose and the duration is. And the reason there's controversy is because these beautiful randomized controlled trials don't exist. They simply don't. So people operate on opinion. A typical protocol for using these drugs in Duchenne's, and I have been doing this for the last 20 years, involves the use of an intravenous drug. We can use a drug called pamidronate. That's the older one we have a lot more experience with. It's once every 3 or 4 months. The other newer drug, zoledronic acid, we are beginning to use, and that's every 6 to 12 months. So these involve an infusion over 4 hours for PAM, over 1 hour for Zol, in our day hospital where you would go for other infusions. And we treat until final height is reached. The bisphosphonates appear really to help with these vertebral fractures and also reduce the peripheral fractures. This is probably one of the best studies, but very small, only 7 patients, but they had a total of 27 vertebral fractures, so you can understand many had more than one. And at the end of the 2-year period, 17 of those 27 fractures were better, 10 were stable, and there were only 2 new ones. So it seemed to reduce or halt this progression of difficulty with the spine fractures. In terms of side effects, the most common issue is after the first infusion. The body tends to have a fever, achy, sometimes nausea or even vomiting. And we treat with Tylenol and drugs to stop the vomiting. And fortunately, it doesn't occur with the later infusions. It's just the body's reaction to these drugs. We make sure the calcium and vitamin D are adequate before we give the drug to avoid that side effect. And serious side effects that have been reported in adults appear not to be a problem in children. So in conclusion, fractures really are a major cause of morbidity, reduced quality of life in Duchenne's. It's important to pay attention to these other general measures. And again, the Duchenne's clinic at Stanford does a great job thinking about all these things. The drugs, the bisphosphonates, they're not a perfect cure, silver bullet, but they really, really do help reduce the fractures, and they still a valuable and effective tool. So a care plan for now involves using your physical therapist, optimizing the vitamin D and calcium, giving testosterone as puberty is delayed, and considering bisphosphonate, and that's usually some conversation I can have with families. On the horizon, people are talking about doing trials to prevent a first fracture, and there's discussion about having us, the centers like ours that are interested in this, getting together to work on trials. And there are also newer drugs, which I'm sure you're going to talk about, that have the effect of reducing the inflammation without some of the side effects of the traditional steroids, the prednisone and the deflazacort. Collaboration is really, really key. Collaboration amongst the subspecialists at Packard. From my perspective with the other DMD centers, I was at a wonderful meeting last May in Bethesda with international Duchenne's people interested and parents there to support. And is collaborating with families like yours. They're really, really important. And from my perspective, I am a half-full person. Working together, I do think that bone health can be looking up in Duchenne's. Thank you.